Good afternoon and good morning to everyone, and welcome to the 2021 Healthcare Project Delivery Conference. My name is Jennifer Hara, and I am the conference director. On behalf of our entire team, thank you for joining us today, tomorrow, and Friday. It goes without saying that the COVID-19 pandemic has led to immense changes in nearly every area of healthcare operations, and project delivery is no exception. While some things have remained consistent throughout the last year, managers overseeing the planning, scheduling, and performance of construction projects have had to adapt to a new range of considerations, many of which we will explore over the next 3 days. We're really excited about this year's program. Since last year's event, there have been a number of interesting examples of owners in the market updating their views on project delivery and thinking about collaboration and integrated models to see where they fit into this new normal. The cost of these facilities and the link to value, performance, and patient outcomes is more important than ever before. And we'll be talking over the next three days about new approaches owners and their partners in industry are taking for new developments, project upgrades, and innovative ways to harden resilience, realize sustainability goals, face social and racial inequities, and meet long-standing deferred maintenance challenges. We'll get into the technical details of a lot of different kinds of projects. We'll talk about how projects get procured, structured, financed, and speak about the roles and responsibilities of different project stakeholders. We'll talk about risk, ways to coordinate among all the different parties, and how to build partnerships that align interests and deliver the best results. We're excited this year to have over 100 speakers who will bring their insights, innovations, and experiences to share with all of you. The program will look at some specific projects, such as the new hospital at Howard University in Washington, D.C., the Oklahoma University Medical Center Patient Tower in Oklahoma City, the Ambulatory Transformation Project at Rush University Medical Center in Chicago, and the Children's National Pediatric Research and Innovation Hub, also in our nation's capital. But the program will also speak to the broader context and the relationship between the owner, the stakeholders, the community, and the patient. We'll talk about value-driven healthcare, how to institutionalize best practices, and be smarter about the link between the quality of the facility and the quality of healthcare outcomes. As the pandemic has forced us to realize that we are truly all in this together. We'll be discussing a range of projects from full-featured hospital, behavioral and community health facilities, all the way to more modest clinics, and everything in between. There are secular trends moving from inpatient to outpatient and ambulatory care, and today it's not just about future demand of hospital beds, but more value-focused, outcome-based healthcare. Conversations here about how to modernize facilities, adopt new technologies, repurpose space, configurations that for owners will absolutely be necessary as we move forward in a post-pandemic world. 80% of the cost of the facility is in the lifetime maintenance of that building. The role of those focused on project delivery play an important role in reducing costs and producing better outcomes. Additionally, the conference is also meant to be a safe environment for learning. All opportunities and ideas should be on the table, and your questions should be asked. Over the next 3 days, we'll be able to learn from each other, find new ways to think about healthcare project delivery, and listen to what our peers have been facing since we last gathered in San Diego 1 year ago. Hard to believe. We will all do our best to benefit from the collective experience of our attendees, speakers, and exhibitors by tuning in and asking questions. Please be curious. Though there's nothing like being together face-to-face, 2020 and now early 2021 had other plans. All of the over 35 sessions are available live over the next 3 days, and then will be available on demand through the end of March. But take advantage of what's live, who's available to network, and connect with our speakers, whom you can meet after each of the sessions in the networking hall. Don't be shy. Introduce yourselves. Take a second right now and say hello in the chat box to the right. Additionally, this is where you'll be able to ask questions during our many panels. We appreciate that so many of you have made time to join us to share your current challenges and outlooks. As you know, our conference is focused on partnerships and their role in project delivery and lifetime asset management. And this is truly a time to understand the nature of partnerships and how they are performing. There's a lot to cover. And you can see the whole agenda in the program guide in the Resource Center. Many of the sessions will have slides and presentations, which we will make available next week. Next, I would like to thank all of our program partners, our speakers and moderators who've been generous enough to share their experiences and expertise, and also, of course, our sponsors. This event would not be possible without their involvement, and we are fortunate to have some terrific partners that are active in projects of all sizes and have a long history of bringing these projects across the finish line. Specifically, I would like to thank our diamond sponsor, Plenary, whose partnership has been so important to us this year and who will be sharing some remarks in a few minutes. I would also like to thank our gold partner, Sea Power Energy Management. Please be sure and visit their booth in the Expo Hall. And to our silver sponsor, Johnson Controls. And finally, to our exhibitors, Better GIS, Forbo Flooring Systems, HHI Corporation, M-Bar-C Construction, and Next Era Energy. Thank you all for joining us this year. And finally, to our program partner, AIAI, the Association for the Improvement of American Infrastructure. Please be sure to visit the Expo Hall to explore and connect and network. Each day in the networking hall, in the Expo Hall, we will hide 3 hospitals. This is a bit of an Easter egg hunt. Visit the help desk and let them know that you found them to be entered for an Amazon gift card. And additionally, the help desk is available to answer any questions you may have about the conference. These sessions in our program over the next 3 days are the beginning of a conversation, not the end. Reach out to others through the chat function on the conference platform and join us at the end of each day in the networking hall that you can also access at the bottom of the platform and also back from the lobby for a bring your own beverage happy hour. Finally, we would like to say a huge thank you from this community to yours for all that you have given and continue to give throughout the pandemic. On behalf of the Healthcare Project Delivery Conference team, thank you to our frontline healthcare workers. I would now like to introduce Sia Kusha. Sia is the Group Head of Project Development and Partnering for Plenary Americas. He is responsible for Plenary's strategic business development, partnering, and project development activities across North America. Sia is based in Tampa, and he coordinates Plenary's efforts to identify and assess new markets, project opportunities, both buildings and civil, liaise with relevant authorities, and solidify teaming. And he has an amazing wine cellar in his house. Sia, thank you so much for joining us. Over to you.
Thank you, Jennifer. Good afternoon and good morning, everybody. It's my pleasure to welcome you to this year's conference. As Jennifer mentioned, I represent Plenary Americas. We are the most successful private investor, developer, as well as operator of public infrastructure in North America. We currently have over 53 assets under management. Of those, 47 are in operation, 6 are under design and construction, as well as implementation. Of the entirety of our program assets, 16 of them are in healthcare, greater than almost any other developer in the space. Today, I have the pleasure and the opportunity to introduce to you my dear colleague, Angela Clayton, who is responsible for our delivery of the vertical assets within our portfolio. And Angela is going to spend the next hour along with Tom Johnson, who is Executive Director of Facility Services for the Carle Hospital Foundation. Angela, over to you.
Thank you, Sia. Appreciate that introduction. Hello and welcome everybody to the opening session of the conference. Tom, thank you so much for joining me here today. I know the audience is interested in hearing your perspective on healthcare project delivery and some of the trends you are seeing. So let's just jump right into it. Why don't we start by taking a look at the sector as a whole, and maybe you can share with us your thoughts on broader trends we can expect to see when it comes to how the healthcare projects or how healthcare projects are currently being delivered.
Sure. I'm in the facilities end of things, so we like to joke with our projects department. They build it, I fix it. But really, we work together quite well. One of the things that's had a significant impact upon construction in our organization is just the interruption of the revenue stream last year, which really shortens the amount of capital that we have this year. So we're looking to be as efficient as possible with the projects that we do move forward. So anything that we can do in the project world, BIM modeling, or anything we can do to reduce change orders and expenses is a welcome use of our capital. So we have considerably less capital this year, and I think with the impacts that we're having, even in the beginning of this year, we're going to see a shortened capital list next year as well. So that's probably the biggest impact that I've seen, is just the overall reduction in the amount of capital available because of the impact, the economic impact.
Yeah, I would say I share that observation, and Sia would certainly agree with me that we've seen an impact on the pipeline of projects that are scheduled to come to market. And that's not just healthcare, that's all asset classes. I think everybody's kind of feeling the economic repercussions as a result of the pandemic. But maybe I'll just share quickly what Plenary's observations has been. So I'm going to have to correct Sia. We actually have 22 healthcare projects in our Canadian portfolio. About 2/3 of those are acute care, and 1/3 of them are long-term care. So Sia might have forgotten the acquisition that we made last year to acquire a number of long-term care facilities. And a few trends that we're seeing related to the healthcare portfolio are basically speed, model, and size. So just let me describe each of those quickly. We're seeing healthcare projects get built quicker. I think part of that's out of necessity as a result of the pandemic, but also just due to innovation in construction means and methods. So, the schedules are getting tighter, a bit more aggressive, which is great. We're also seeing different types of models being used. So for the past 10 years, the predominant delivery model for healthcare in most parts of Canada has been the P3 model. And we're now seeing a resurgence of more traditional models. So things like CM at risk and design build. As far as I know, we've yet to see a IPD or Alliance greenfield healthcare project in Canada, but I imagine that's certainly in the works if it hasn't happened already. And just lastly, I'll just say the projects are getting bigger. So we have 3 greenfield healthcare projects over $2 billion that are scheduled to come to the market in the next couple of years. So I think they're getting delivered faster, they're quicker, and they're being delivered with all different kinds of models, would be kind of my general observations about the broader market.
I think another thing that's happening is that one of the things we had with people working from home is we found out that we do have a significant number that can continue working from home. So in our health insurance arm of our corporation, we found that the space crunch we were anticipating with the growth in there has been somewhat relieved by people working from home. So we probably won't be building an office building as soon as we thought we might need to because of our ability to flex people from home. Now, traditionally, healthcare is, at least in the acute care setting, has to be done on site. But one of the things we do find is that those ancillary services, insurance and accounting and some of the other things, more of it can be handled off-site. So I think it gives us greater flexibility with the existing buildings, which may reduce the need for new buildings.
Yeah, that's a great point. I think everybody's kind of reassessing what their space requirements are right now. So let's talk a little bit about COVID. It's obviously had a significant impact across the sector. What did you find were some of the greatest operational impacts as a result of COVID, and how did you and your team manage those?
For us, it was really in the building automation system and being able to manipulate air exchanges and pressure relationships. With the need for negative pressure, we used up all our negative isolation rooms rather quickly. And then it was modifying the existing rooms so that we could change the airflow from the hallway. Instead of being neutral, change it from the hallway into the room. Even just a little bit helps tremendously with making staff feel much more comfortable working in that environment because they're worried about their health as well. So, and then the utility impact with us exhausting more of the air that we have and trying to bring in 100% outside air. We can do that in the shoulder months, but during the design days of height of summer or the depths of winter, a little harder to do. So you have to manipulate it. So from that perspective, we found that the return air that was coming back through our air handlers, we were looking at disinfection methods. Now, fortunately, we had a lot of UV lights, UVC lights in our air handlers already, several of them. But the data is still out on whether the air is actually in the air handler long enough for the UV light to have an effect on the viruses. Typically, we use those UV lights to limit bacterial growth in our coils. So we were glad that we had the UV lights in there, but we weren't quite sure that that was the effective method. So now we're looking at bipolar ionization, adding that to a number of our air handlers. So I think in the industry, you're going to see that being spec'd on a lot more air handlers, or with the UV lights as studies come out that prove the efficacy of those things. We were asked a lot to determine the number of air exchanges for a room. The CDC has guidelines for the number of air exchanges before you've typically exhausted, and we like to shoot for 99.9% of the air. So for 6 air exchanges, that takes 69 minutes. So they were looking at anything we could do to increase the number of air exchanges so that whether we were using HEPA filters or just exhausting more air, so that we could shorten the turnaround time in those procedure rooms, both the OR and some of the outpatient procedure rooms. We needed to enhance the security and monitoring of all the people that were coming into our facility. We locked a lot of doors from entry. Of course, you know that we can lock a thief out, but we can't lock them in. So everything had to be able to go out yet, but we needed to restrict access to checkpoints where we were checking the temperature of contractors coming in and staff. So the security we needed to do, that increased markedly. And then our O2 usage. We found that our vaporizers were freezing up much faster because we were going through more than twice the amount of oxygen that we normally would. So we're currently doing some maintenance on those vaporizers to keep them de-iced, and then we're also looking at larger vaporizers as well as increasing our O2 capacity as well. We had to set up in very short order a number of off-site clinics or drive-through testing sites. And so that was a challenge from a facility standpoint. We partnered with a lot of our construction firms here in the Champaign-Urbana area to help us get those areas set up, provide shelter, heat, or cooling, as it may be, for the people working in those drive-through facilities. And then just the social distancing. We're constantly being asked to put up signage or barriers or something to limit people seating in meeting rooms or in the cafeteria. Also in our waiting rooms. Eventually we ended up restricting visitors as well. So that helped with the parking crunch, but didn't do much for the happiness of the families of our patients that were in the building.
Thanks, Tom. And I'm sure a number of your colleagues in the audience have been dealing with many of the same challenges. So maybe I'll just take this opportunity to remind everybody that you can ask questions or post comments using the comment function that you would see on the right side of your screen. And so Tom, obviously COVID, I think everybody was certainly in reactive mode leading into wave 1, a little bit better prepared for the second wave. What do you see as some of the emerging trends that we're going to see as we, eventually transition into post-COVID? What are some of those things that you think are here to stay? Oh, Tom, I think you're still on mute there.
There you go. Thank you. I think some of the technologies with regard to sterilization or disinfection of surfaces and air are going to be huge. Like I talked about earlier in the airstream, we're looking at filtration, HEPA filters. It's not easy to switch to HEPA filters immediately. It's a different size filter, would require reconstruction of the rack, and we can't shut down the air handler while we're using it. So unless it's designed in the front end, HEPA filters weren't really an answer for us. And the UV lights, again, that requires that it's in place on the install, not retrofitted later. That's a little hard to do while you're using it. So, but I think HEPA filters and UV lights in air handlers are going to be requested more often, or at least spec'd or examined. And then the bipolar needle point ionization. That's something that can be actually retrofitted into an air handler down the road. I think that holds the most promise. It actually has been tested on the SARS-2 virus, which is very similar to the coronavirus that causes COVID-19. So there's some efficacy there. But again, a lot of it is we're still just looking at what's the science out there. We want the proven technologies. We want to be leading edge, but not bleeding edge. I think surface disinfection too. UV lights, you see a lot more. We were using UV lights to sanitize N95 masks so that people could reuse them because there was a PPE crunch. The UV lights, the robots that are used to sanitize a room after a procedure gets all the surface infections. And then antimicrobial surfaces. There's some research out there, a couple of white papers, nothing really widespread yet about the antimicrobial properties of copper and copper alloys. So high touch surfaces, doorknobs, elevator buttons, those kind of things. Can we use copper to help cut down on the spread of infection there? I think we've also noticed that because of the measures that we've put in place as far as isolation, social distancing, masking, all that, we've really had not seen the flu season like we normally would in our hospital. And I think that's probably been widespread across the country. I think in the construction area, we'll see a lot more isolation rooms being built as we realize that COVID-19 was hopefully on its way out now. But there's going to be something else that comes along down the road, whether it's COVID-22 or COVID-23 or whenever the next one comes along. And I think one of the other things that will be extremely important, at least in the acute care setting, is the creation of pandemic floors, where you can physically and from an air standpoint, isolate those floors from the rest of the hospital. We've done it by putting fans in windows and drawing all of the air that's in the room out through the window. But I know there's some other hospitals, and I've worked at a few of them, that actually had it in their building automation system where they could isolate a floor, and it had its own dedicated air handler. I think you're going to see more of those coming along.
Yeah, I would agree. I think definitely at the operational level, focus on infection control and sanitization, absolutely. And I agree, we're kind of seeing the same thing as far as design trends. There seems to be a big push or movement towards flexibility, right? So just the ability to modify how spaces are used depending on what how the surges or different changes in demand. And we see that in the conversion of negative pressure rooms, which you touched on. So being able to create that negative pressure through building automation and design, conversion to intensive care and critical care units. So the flexibility to move back and forth, again, depending on what the demands are. I'll just quickly share a story from our own portfolio. So we had a acute care hospital that was completed earlier this year, net new capacity, first new hospital for this region in over 20 years. And the decision was made to actually postpone the opening of the hospital to the general public and instead use this facility explicitly to manage COVID cases. And so, the hospital was able to respond very quickly to be able to maximize the space that they had in order to manage the COVID cases. But of course, it brought to light some opportunities where had we designed it with a little bit more flexibility in mind, of course, hindsight's 2020, it would have been a lot easier to make that conversion. So, okay, well, I'm sure there's going to be lots of conversation about COVID for the rest of the conference. So why don't we switch gears a little bit? So Carle Health recently announced that you guys are going ahead with the Danville expansion. Can you tell us a little bit about that project and the model that's going to be used to deliver it?
Yeah, I was having a conversation with our director of projects and construction, and he said it's really more of an IPD light methodology to build that. So we have the designer, we have the construction firm, and we have the users, of course, all working together. They're not all on the same contract, but we are working through the design together with everyone there. And it's interesting how it's changed our philosophy a little bit the past year. Some of the design features we're looking for in that building. We're looking for, since it's going to be mainly a clinic setting with medical office building, we're looking for some isolation areas right up at the front near the entrance to the hospital, both for airborne and droplet-borne infections, TB, COVID, SARS, whatever might come through the door, but also for some of the more mundane problems, bed bugs. That's actually, I've talked to our pest control guy, and that's actually an unseen epidemic that's going on. Bed bugs are everywhere, and we're looking to be able to isolate patients that come to us that may have whatever type of infection, whether it's something that they have or something that they have on them. So that's a challenge in a clinic setting. We're also looking at the ventilation system there. Do we have ducted returns in those areas where we need to be able to control pressure relationships? And can we go with plenum returns in maybe some more of the office areas? So it's changing our design a little bit on the fly as we go.
And what's the timing for what's the schedule for that project? When are you expecting to bring it to market and target completion?
We're expecting summer of 22. So we're still in the design phase now. We've secured a lot of the property, and there's some preliminary work going down for the site, but we haven't broke ground yet, and it's going to be a short timeline. Of course, there's always that dichotomy between facilities and projects. I would like everything, and projects has to have a budget and a timeline that they live with. So we compromise. We look for what's the best value added option. We were looking at rooftop units. If we went with a standard unit, it'd be very hard to service them. But we needed to shave some costs off it, so we decided to go with the plenum return in some of the areas, not all of the areas. And that ductwork change will save us the money that we needed to save, and it allows us to put the custom rooftop units in so that we have ease of serviceability. All of our buildings need to be energy efficient. Again, with the budget crunches, we need to keep those costs per square foot on energy down as low as we can. And I think just recently we've seen the prices in Texas spiking, and that's what we want to avoid with both being energy efficient and judicious on how we purchase our utilities.
I'm going to go a little bit off script here, and I know you and I had a conversation about this. So you mentioned obviously your role is focused on facilities, recognizing that we're here to talk about projects and delivery. What are some of the things that you would share with this group just about how your team is structured, how you interface with the project group, what works, what doesn't, some of the lessons you've learned over your many years of experience?
We're lucky that we have a good working relationship with the project departments. We both report up to the same VP. We're both at the same level, so there's not a difference in roles, or at least in the hierarchy here. We have regular meetings with them. I think communication is one of the keys. So every Wednesday we have an hour-and-a-half meeting with projects, and they run through each individual project, letting us know what shutdowns they may have coming up, because of course we help with those. My team investigates them and helps manage those shutdowns. There's paperwork, permitting. There's interim life safety measures, or as some of the deeming agencies call them now, alternate life safety measures that need to be put in place if we're shutting down any parts of the fire alarm system or compromising life safety. We have infection control risk assessments that have to happen. We have hot works permits. So that meeting once a week is a great time to clear the air on that, to make sure that we're not overscheduling the number of shutdowns we have in a day. We help with explaining the impact to the operations, so that if they're ripping up a floor, we may tell them, well, you may not want to do it during the time frame that you initially proposed, because the floor up above is going to be occupied and you're going to get some calls. So I think that communication piece is key. And then we're actually involved in some of the design considerations as well. Like we were talking about the Danville project. The facilities director out there and myself are both on conversations when we're running through what's going to be installed out there, the type of equipment, how we like it installed. I like VAV boxes where we can access them. We do not like ice machines without drains. One of the things we found is that the ice machines that recirculate the melt water have bigger problems with colony forming units when we do our water testing out there. So we don't even like the hands-free faucets. The chambers in there tend to be places where nasties can hide. So from an infection control standpoint of not touching the faucet, it's a great idea. From colony forming units living inside that water faucet is counterproductive. So we've actually worked with infection prevention and the projects department to specify no more hands-free faucets. So I know that there's probably a lot of projects out there that are still getting those because infection prevention likes them.
I know that one to me is just shocking. It just seems so counterintuitive, right? They tell you not to touch anything. So when you're washing your hands, you'd think, but I guess it makes sense. And this is a good segue into my next question, because I'm sure there's a lot of really smart people that came up with that conclusion. But of course, Carle is unique in that it's home to one of the world's first engineering-based medical schools. So can you tell us a little bit about the organization's commitment to innovation and transformation in the medical field?
Yeah, this has been quite the journey. It's ongoing for a while, and we just got provisional accreditation for the program as well. We have our second cadre of students moving through that. It's really an intersection. It's having medical students actually take engineering classes as well. So when they see an issue during their medical career, they have a better understanding of maybe there's a technology we can adapt or modify to solve that problem. So I'm really excited to see when that first class graduates, just some of the things they've come up with. We've partnered with the U of I on other things as well. The U of I actually developed a single-use ventilator, pneumatically powered, for COVID patients. Had we hit the surge point where we needed to move off-site with COVID patients, we actually planned with them. But that medical school with the engineering aspect to it, I think is going to make doctors that can come up with more solutions to the problems they see in the clinical world, because they'll have an understanding of the engineering and the technologies that are available to help address those. And it's not always something radically new. Sometimes it's the combination of two different technologies and that can create something new. I like to use the example of wheels on the suitcase. We've had the wheel for thousands of years. We've had the suitcase for hundreds of years. And it was only a couple of decades ago that somebody had the bright idea to put wheels on a suitcase. So neither of them were radically new technologies, but they were an application that somebody saw a need by combining two technologies. So I think we're going to see the same thing with the College of Medicine here at the U of I, that they're able to take maybe existing technologies or new technologies and give them a medical application. And that's going to be better for our patients. The more that we can come up with and keep them out of the hospital, keep them well, or shorten their stay here, the better off they are.
Yeah, I think that's great. And obviously, you know, the idea of the disposable ventilators is an interesting one. Obviously, ventilators and PPE in general was a big issue during the first wave. So I think, you know, it's that type of necessity that often drives some innovation, right? So I think that's great. Good for you guys. Let's talk a little bit about innovation in the context of energy. I know you've done some really interesting things over the last couple of years to improve energy efficiency at the campus. So can you tell us a bit more about what those things were and how effective they were?
Sure. Anytime I can not send money to the utility company and roll it back into a nonprofit organization, that gives us more money that we can use for patient programs. And the nice thing is Ameren, who is the local utility supplier here, incentivizes us, gives us rebates for that. Even though I'm paying for that rebate, I see it on my bill. And I'm not even probably getting back all the money that I've paid in, but I try to do as much as I can with the rebates. But we don't focus on the rebates. We focus on the energy saved. We want to be good stewards. That's actually in our mission of the resources that we're given. And part of that is the energy that's available in the community. So any air handler we put in is going to have VFDs on it. We put VFDs wherever we possibly can. I don't want to run things at constant volume. So we put VFDs everywhere. And then we'll retrofit some of the older units whenever we can. But they go on pumps, they go on motors, everywhere. The other thing is LEDs. And those are really nice because we get an instant rebate on them. So when we order the lights, they're already at a discounted rate due to the program that Act on Energy that Ameren has provided. So LEDs everywhere, certainly in our exit lights, because exit lights love to give up the ghost the minute a surveyor walks through the door. So we like to see LEDs there. And they generate less heat. So it's less of a cooling load as well. And then we've done retro commissioning here. We actually about I'd say about 3 years ago, we did a retro commissioning project where we looked back at how the building was originally set up and how it's migrated away from its original settings over time. It was really useful to involve my staff in that because there were setbacks that the consultant found that they wanted to implement, but we had to take a look at how we were operationalizing that building. And the setback wasn't quite appropriate because it would take too long for the building to come up to temperature or get down to cooling if it was set back at night too far. So we used a lot of their ideas, but not every single one of them. And we had to implement based on what staff said would work operationally, what they see every day. We also use energy purchasing strategies. So we buy a fixed rate, but we buy it at the most opportune time, and we do it as a system. So I get a number of the facilities directors together. We're able to look at our past spends and our knowledge of how pricing goes. And then we partner with our energy purchasing company as well. And then we involve finance in it because really we're risking a lot of dollars for our utility bills. I have upwards of spend of $5 million that I'm responsible for. So that's something I want to make sure that finance is at the table and they're comfortable with us locking in rates for the period of time that we do and letting float what we do. So it's a partnership when it comes to purchasing strategies. We've looked at some new technologies too, variable demand exhaust hoods in our new kitchen project. So there's both a particulate and a heat sensor in the hood. So the hood isn't running continuously. We've also looked at some of our walk-in coolers and putting a high efficiency 2-speed motor on the evaporator fan motor so that when the walk-in cooler is calling for cool, the fan runs at high speed, and then it runs at low speed when it's not, just to keep the frost off the cooler. And then we've closed stairwell doors. We found that on the ground floor we had a lot of stairwell doors open for convenience for people to go up the stairs, and during the winter that contributed to building stacking. So at our entrances we were actually drawing in more cold air just because we had those stairwells willing to take the hot air up to the upper levels. So something as simple as closing stairwell doors on the ground floor level has really helped with energy.
Yeah, it definitely doesn't always take significant capital investment to get some energy savings. Maybe I'll just share one aspect of the P3 model that has worked really well when it comes to energy efficiency is the pain share, gain share model. So the way that works, the bidder includes an energy model, their forecasted consumption with their bid, and after a waiting period to allow the building to get into steady state operations, usually about 2 years, the energy is normalized and then compared against that benchmark. And if consumption's greater than planned, usually there's a threshold about 5% plus minus. If it's over that, the costs are shared between the owner and the operator. And if it's under that, the savings are shared. And so it incentivizes the right behavior. And some of the most efficient hospitals that we have in Canada are actually P3 hospitals. And we think that's a big part of it. But Tom, we do have a couple questions from the audience. So let me just, one's for you and one's for me. So let me pose your question first, and then I can try and tackle mine. So the question is, how confident are you with plenum return for healthcare space, especially considering future operational flexibility and discussion of liability, if any?
Yeah, that was a tricky one, and we I actually was opposed to it. I was if it came to one or the other, I was going to give up the custom RTUs, the ducted returns. We've had buildings that's always, there's an added expense of the cabling that has to go in there. It has to be fire rated for a plenum. And then I agree wholeheartedly. It reduces the flexibility of turning some of that space into clinical space. We're primarily focused on using the plenum returns in office areas and things like that, which means the walls have to go to the deck and for noise reduction. So I'm not a huge fan of it, but I listened to the director who's actually going to have to service or be responsible for that building, and he would rather have the RTUs. He wanted the ducted returns too, but we have to make that value judgment, and it will limit our flexibility down the road with transforming, say, an office into an exam room or something like that. So there is a downside to it. I agree with that. And my preference would have been to have ducted returns, but sometimes you have to make a compromise to get the project to go.
Thanks, Tom, and thanks, Henry, for the question. The second question directed towards me was just an observation that it was an interesting statement that I made about Canada's move towards traditional procurement models for healthcare projects and what the reasons for that change might be. So a little bit of speculation here, but I think it's probably two main things. One is with regards to schedule and just speed to market. So certainly, at least in Ontario, we've seen a big push to increase capacity in long-term care facilities. And, the government has mandated additional capacity to be delivered by the end of this year. And in order to meet that aggressive of a schedule, you need to go with the quickest model possible. A P3 model just isn't really viable for a turnaround that quick. And so the government decided to go with a construction management at risk model for the execution of those projects. And then in other parts of the country, I think a lot of it has had to do with risk allocation and just determining which party is best able to manage the risk. So, for example, there was a brownfield hospital project out in BC, and the government took a look at the P3 model, decided that there was too much risk with regards to some unforeseen and existing conditions, and decided to deliver that through a traditional design build. And so I think, we've had a great run with P3 projects. I just think governments now are just taking a step back and kind of revisiting all the tools that are available in the toolbox and, having a second thought about how they want to execute their projects. It looks like we have about 9 minutes left. So again, if there's any questions from the audience, if you want to just put those into the chat box, that would be great. Tom, we were kind of on the subject of energy and innovation. What do you think is the biggest innovation opportunity in the industry, and whether that's in regards to project delivery and or operations? Just kind of curious on your thoughts there.
I think the monitoring and metering, you can't improve it if you can't measure it. So we've tried to get some sub meters to different areas. Unfortunately, in healthcare, some of the energy savings, we can't do things. If the surgeon's operating, that room's got to be cold. So there's things that we can and cannot do, but it allows us to catch problems if we see a spike in something. So the more real-time monitoring we can do to help catch problems before they become an issue. We're doing a monitoring-based commissioning now. After we finished the retro commissioning, we didn't want to backslide. So, but what we did is we said, rather than meeting monthly about the things that our commissioning company finds by looking at our building automation system, what we're going to do is we're going to have them send us the data monthly, but then we'll meet quarterly, and that allows our guys to address some of the issues immediately when they can find them. And then on the monthly, we should be just really summarizing what we're doing or explaining why this might be an issue, but it's going to have to be the way it's going to have to be. So that's staff participation. Again, to your point about behaviors, you can save more energy with behavior changes than you can with any technologies, I think. People turn off lights, close doors, use energy efficiently, don't leave flow meters for medical gases on all the time. We can save a lot of money, and that's money that doesn't take service away. We're not being conservative with our energy. We're not restricting the use of energy. What we're doing is we're using it more efficiently. So we still get the same output, but we can do it with less input. And I think that's the goal of energy efficiency. I'm a big proponent. I would like to see more green roofs, and green roofs can be a white reflective roof, or it actually could be what I'd like to see is more low intensity green roofs where you have tray systems of plant material on top of your roofs. The plant material protects your roof membrane from UV. It reduces the amount of stormwater runoff, and then it provides cooling in the summer because the plants are expiring water, which provides a much cooler roof. In fact, I think there was a study done in Chicago, a county building. On one half of the roof is it's the county and it's a traditional ballasted roof. The other half is the cities, and they went with a green roof. And on the hottest day of the year, I think the city's roof was 98 degrees and the county's roof was 130 degrees. Well, that's a significant difference in the amount of energy you're going to have to expend to cool that incoming air to your air handler. So I'd like to see us follow the European models wherever possible and get rid of the heat islands that we have on our roofs. I like the tray system because then I can still access a roof for repairs or leaks or anything like that. And I think it also reduces the amount of stormwater runoff that the municipality has to handle. So that's an emerging trend I'd like to see more of.
Plus, they look good. Yeah. That's great. Thanks, Tom. Just one more question from the audience here, and then I'll let you have the final word so we can wrap up on time. So the question was just, again, regarding the Canadian market and whether or not there's a potential for increase of new projects should the government move away from the P3 model and start using design build. And I think it probably, the shift in delivery model probably won't change the volume of projects. I think it might change the composition of projects a little bit. What we're starting to see is more provincial governments communicating publicly their pipeline and their approach to project delivery. So Ontario has had a long-standing practice of publishing its pipeline of projects coming to market. BC, British Columbia very recently also published their first pipeline, which includes all of their delivery models. Alberta and Saskatchewan have also recently communicated their project delivery methods. So I think it probably won't change the number of projects. We're also struggling with the capital crunch as a result of the pandemic. So I think there's a little bit less money there right now to spend. But it's great. I think, again, it's good to see governments considering all the potential options as far as delivery goes. So Tom, we got 3 minutes left. Any final words of wisdom you want to leave with our audience here?
I think that communications between construction and operations is the key to any successful project. There needs to be some ground rules set in the beginning. I cannot expect every construction project to solve all of my infrastructure needs, and we have to be aware of scope creep, where we have an air handler that serves this area that doesn't have a lot of capacity, but that's not on the docket to be replaced as part of the remodel. So that communication piece between, and we can inform the projects people on just where there's vulnerabilities. You know, we have a lot of emergency power in this area, but we're short on air, or whatever the issues are. We can give them the history of those spaces and what can be problems. So I think that communication just often during the design, certainly during the construction, and then afterwards are just key to a successful project that really makes the owner feel like they've gotten value for what they've bought. And for the facilities people like myself, we have a building that's great to work with. Addresses some needs and some issues. So again, just communication.
Well, we'll leave it at that. Thanks, Tom. Really appreciate chatting with you today, and I'm sure the audience appreciates your insights as well. And I'll just take a moment to remind everybody, please join the next plenary session about the Children's National Research and Innovation Center, which I believe is being held right here in the next couple of minutes. So thank you, everybody. Enjoy the rest of your conference.